Hello, my name is Dr. Benjamin Weinberg, and I am a gastrointestinal medical oncologist at the Rush Center for the Cure of GI Cancers at the Lombardi Comprehensive Cancer Center at Georgetown University in Washington, D.C. Today I will be talking about a review article highlighting the use of trifluridine tipiracil, or TAS-102, in the management of patients with metastatic colorectal cancer. Treatment options for patients with metastatic colorectal cancer have expanded in recent years. Typically, patients are first treated with chemotherapy regimens using fluoropyrimidine in combination with oxaliplatin and/or irinotecan, along with the addition of biologic agents, including the antivascular endothelial growth factor antibody bevacizumab or the anti-epidermal growth factor receptor antibody cetuximab, which is restricted for use in patients with RAS wild-type tumors. Second-line therapies frequently employ fluoropyrimidine combinations not used in the first line, plus continuing the first-line biologic agent or switching to another vascular endothelial growth factor targeting agent such as ramucirumab or zivaflibercept, or if RAS wild-type, the other anti-epidermal growth factor receptor antibody, panitumumab. Patients with mismatch repair deficient or macular satellite instability high tumors also benefit from immunotherapy checkpoint blockade with the anti-programmed death 1 antibodies pembrolizumab and nivolumab. Now, there are standard approved therapies for patients who have progressive disease despite the above regimens. These novel oral drugs are TAS-102 and regorafenib. Trifluridine, the key component of TAS-102, is actually an old drug that has been around since the 1960s. Similar to fluoropyrimidines, trifluridine inhibits thymidylate synthase, blocking DNA synthesis and leading to cell death. Unlike fluoropyrimidines, trifluridine is also directly incorporated into DNA after being phosphorylated to trifluridine triphosphate, leading to DNA damage and cell death. Given this alternative mechanism of action, trifluridine is active in fluoropyrimidine-resistant cancer cells. Trifluridine is rapidly metabolized in the bloodstream and has a short half-life of only 12 to 18 minutes. However, in combination with tipiracil, which blocks the trifluridine-degrading enzyme thymidine phosphorylase, the bioavailability of trifluridine is dramatically improved. Of note, thymidine phosphorylase is also a platelet-derived endothelial cell growth factor, and inhibition with tipiracil has indirect anti-angiogenic effects. TAS-102 was ultimately approved at a dose of 35 milligrams per meter squared by mouth twice daily, days 1 through 5 and 8 through 12 every 28 days, based on the RECOURSE trial. This study demonstrated that median overall survival was longer with TAS-102 compared with placebo, 7.1 versus 5.3 months, although objective response rates were very low, 1.6% with TAS-102 and 0.4% with placebo. TAS-102 is frequently contrasted with regorafenib, an oral polytyrosine kinase inhibitor with anti-angiogenic properties. However, whereas TAS-102 causes more neutropenia, regorafenib causes more hand-foot skin reaction, fatigue, and diarrhea, although these two agents have not been prospectively compared head-to-head. Exploratory analyses have suggested potential positive predicted biomarkers of efficacy of TAS-102. These biomarkers include treatment-induced neutropenia, more than 3 lines of prior therapy, and tumors with mutations in genes affecting the DNA homologous recombination repair pathway. Finally, clinical trials evaluating different combinations of TAS-102 with chemotherapy, biologics, and immunotherapy are ongoing. Thank you for watching, and I hope you enjoy the article.